Hi, everyone. Thank you for joining us. My name is Dana Friedman. I am a 13-year papillary cancer survivor, and my son is a 1.5-year papillary cancer survivor. I'm here to introduce Luz E. Castellanos, a board-certified pediatric endocrinologist and recent graduate of the endocrinology fellowship at MD Anderson Cancer Center in Houston, Texas. She will be joining their Department of Endocrine Neoplasia and Hormonal Disorders as faculty this fall. After completing her MD at McGovern Medical School, she did a pediatric residency at the University of Texas at Austin Dell Children's and Pediatric Endocrinology Fellowship at Massachusetts General Hospital. After fellowship, she coupled her clinical practice with clinical trial research on artificial pancreas technologies for diabetes. Dr. Castellanos plans to pursue an academic career in specializing in the care of children with cancer-related endocrinopathies and endocrine neoplasia.
Thank you so much for that introduction, and I'm very honored to be here today to talk to you all, and thank you to Gary Bloom for this invitation. Yes, I did specialize in pediatric endocrinology, so I'm so glad that this conference does offer some pediatric focus, and there are a couple other sessions I'll mention that are in the pediatric realm that I encourage you to go to. So I have no disclosures, starting with the make sure I'm on the right side. Yes, no disclosures. For the outline today, we are going to be providing an overview of pediatric papillary thyroid cancer, which I'm going to abbreviate PTC, as well as the management and surveillance involved with this. By the end of the talk, I do hope that you'll have a general overview of thyroid carcinoma and how we manage and surveil this. So starting with what is the thyroid, it is a small butterfly-shaped gland in the front of your neck. It makes thyroid hormones that regulate the body's metabolic rate, growth, and development. And there are two main parts of the thyroid. So you have two halves, you have lobes, and in the middle of that, there's a connection between the two lobes, which is the isthmus. And your thyroid is made of thyroid follicle cells, also known as thyrocytes, which create and store the thyroid hormone, mainly T3 and T4. And then we have the C cells, which secrete the hormone calcitonin, which helps regulate calcium levels by decreasing levels when needed. And papillary thyroid cancer is the most common malignancy in pediatrics and adults. That's really what I'm going to focus on today's talk because it does comprise more than 90% of thyroid cancers. But I am happy to take questions on other types of cancers. The adult side, it's 80 to 85% of thyroid cancers. It does arise from the thyroid follicular cells. It usually presents as a painless thyroid nodule, and that's why it's so challenging to diagnose at the what would be the initial onset, because it's just not an obvious symptoms that it can cause. It can be very discrete. So only 20% of our patients end up having compressive symptoms from it being large. And mostly it occurs as a sporadic tumor, meaning that it wasn't something passed on by family, but 5 to 10% of cases can be familial. And in terms of why kids get thyroid cancer, we don't have a great answer for that. We do know that they get, there's a change to the DNA. And sorry, this is a different slide. So there's, we do start off with the diagnosis of getting thyroid function tests, and then ultrasound, head and neck, not just the thyroid. So it's important that we visualize everything, because if you just look at the thyroid, you may miss suspicious lymph nodes. And ultrasound works by using sound waves to produce images of the structure of the body. And then we also get the fine needle biopsy, which removes a small sample of the tissue through the needle. And this overall is a safe procedure. There's risk of bleeding, infection, and pain, although that's why we use local anesthesia to help with that. And back to the reason why, it's really a challenge to fully understand why these mutations occur, but we do know it's at the level of the DNA that there is a mutation that allows these cells to survive and have uncontrollable growth. So now that we've identified papillary thyroid cancer in a patient, how do we approach the management? So the adults have had evidence-based guidelines for years. So the first effort to standardize this for pediatrics was with the ATA, American Thyroid Association 2015 guidelines. And when this was created, it was mostly expert opinion based on few pediatric data and more adult data. So I'm going to talk about what's currently in the guidelines, but there is a revision being worked on, and we do anticipate some changes to this. So I also want to preface this by saying that there are a lot of different approaches to managing these patients. So what I'm going to present is not necessarily the only way to manage them. There are still a lot of gray zones, and we're learning more about those zones and how to approach them. So the principles of pediatric management include surgery for localized disease, followed by radioactive iodine. And more recently, there is consideration of systemic therapy for progressive disease that's not amenable to the other management that I mentioned, but this is rarely needed. And we know that the best hope for cure for papillary thyroid cancer, especially is with that initial surgery. So the current ATA recommendations is total thyroidectomy, and that's based off this older data that shows higher risk of bilateral disease in pediatrics. And the ability of total thyroidectomy to lower the risk of recurrence and facilitate the use of radioactive iodine. However, we do now consider lobectomy in certain patients when they have disease confined to one side without any evidence of spread to the other lobe or to lymph nodes. And we know in terms of surgery, it's really important that this be done at high volume institutions where there is an expert surgeon, not only for thyroid cancer, but also for that pediatric age group, because kids do have risk for more surgical complications than adults. And we also know that, check the slide, sorry. Going back to that data about the bilateral risk of disease, this is one of the main papers cited in those guidelines that showed a possible decrease in risk of recurrence in patients that had a total thyroidectomy versus a lobectomy. And this was a study that actually occurred out of Mayo Clinic from 1950 to 2008 on pediatric patients. And you can see the kids that underwent lobectomy in black and the kids that underwent total thyroidectomy in white, with the black showing worse local recurrence rates. But I do want to caution that this was at a time that we didn't have thyroglobulin as tumor marker until the 1980s. And there's also lack of imaging standards at that time since ultrasound wasn't widely used. So we're definitely in a different time than when this was published. And that's why practices have steadily been changing. And there are other pediatric guidelines from European countries that I should mention, including Poland, Netherlands, UK. Overall, total thyroidectomy is still the most common, but there are acknowledgements now that lobectomy may be sufficient for kids that have smaller cancers. And in contrast, the adult ATA guidelines from 2015 discussed that lobectomy alone may be sufficient for low-risk thyroid cancer. And we need to be thinking about complications that are more likely with total thyroidectomy, including risk for permanent hypopara and recurrent laryngeal nerve paralysis. So the question is really if we can apply this to pediatrics. And there are data, including national studies, that have showed excellent outcomes regardless of surgery type or whether they get radioactive iodine in certain populations. So we are recently offering this more to our patients that have no evidence of bilateral disease, no evidence of spread to lymph nodes, and no evidence of suspicious lymph nodes during the surgery. And there's also always the risk that we mentioned to them that they may need a completion thyroidectomy in the future. So after, and I do want to mention briefly our study that we did. This was recently published in the Journal of Endocrinology, And this was 93 patients, less than 18 years old, with stage 1 papillary thyroid cancer that were diagnosed between 1990 to 2021. We had at least a year of follow-up. None of them had radioactive iodine. And we specifically also looked at our lobectomy population, which was 20, which shows how often total thyroidectomy was being done. But 18 of the 20 did very well and had excellent response, not needing any further treatment. And this was a median follow-up of 3 years. So it shows that we still need to keep understanding this and what patients are best to select for this approach. And after the surgery, that tissue gets sent to pathology. So that's when the cancer undergoes staging. So we use the AJCC, which is the American Joint Committee on Cancer, TNM system. And this system describes the amount and spread of cancer in the patient's body using the age, tumor, lymph node, and metastases characteristics to determine the staging. So it is important to note that in pediatrics, you can only reach stage 1 or stage 2 based on the age, which is different from the older population, which aligns well with that excellent prognosis that we know pediatrics has. And this makes a nice transition to discussing survival, because we know survival is excellent in pediatrics, especially in localized disease. So we see here the lowest value on the y-axis on this graph is 90%. And these are graphs that usually start at 0%. So again, starting at a good level, and overall, averaging this, the disease-specific survival is 99% at 30 years, regardless of tumor size or procedure. And this is overall survivor, not disease-specific survival. So meaning that overall we're seeing really great results. So there's a lot of abbreviations on this slide, but the main takeaway is that the postoperative staging, we also assign a pediatric risk level, and this is risk for residual or metastatic disease. And this is really dependent on the extent of disease that we see on that initial pathology. So this is something we think about after we get the pathology back, and it helps us come up with a surveillance plan. And again, the guidelines are being revised, so those risk levels might slightly change. So after surgery, we may consider something called radioactive iodine. And this is because the thyroid gland does take up almost all the iodine in the body. And the radioiodine can then be taken up and concentrated in those thyroid follicular cells. And it has been used as a treatment for papillary and follicular thyroid cancer since the 40s and 50s. And we consider this now more for our intermediate and high-risk disease patients because thyroid tissue does have to take up radioiodine for it to be effective, and low risk may not benefit from it, which I'll explain a little more in a bit. But before administering, the kids do need to go through a low iodine diet to make the thyroid hungry. So essentially you're starving it of the iodine, usually for 2 weeks beforehand. So there is some planning involved. And just to explain a little bit about how it works. So it's taken up and concentrated in those thyroid follicular cells because they have a membrane sodium iodide symporter. So the symporter, which you can see at the bottom of the slide, really serves as the driving force for the iodide uptake. And this occurs under the thyroid stimulating. So that's why we have the kids come off of their levothyroxine or Synthroid or do Thyrogen. And that really helps maximize the ability for radioiodine to be uptaken into the cell. And then the version of radioiodine that causes acute thyroid cell death is the I-131. So that works by emission of beta particles, which can only travel short distance. So it's really targeting that area where it has the uptake. And then we can visualize that with the gamma radiation that's also emitted by that same isotope. So that helps us visualize it on those images that we show you during clinic. And I just want to briefly mention the history of radioiodine because it is quite interesting. Over 90 years ago in Boston, Dr. Hertz was at Mass General Hospital. He was conducting animal studies using radioiodine at the same time that other doctors at University of California were studying this, Doctors Hamilton and Soley. And they eventually shared their findings with each other and were able to create I-130 and then I-131. And by the 1940s, radioiodine was studied therapeutically and eventually became the first targeted therapy for thyroid cancer. And another fascinating aspect is this is how the field of nuclear medicine started, was from thyroid. So this was established in Massachusetts. And then in 1942, that's when the first thyroid cancer treatment with radioiodine was applied. This was at Montefiore Hospital, and this was after they consulted with Dr. Hertz. And by the end of the 1940s, this was really being portrayed as a life-saving therapy for thyroid cancer, as you can see in this Life article print of a man who had thyroid cancer and received radioactive iodine. And by 1951, the FDA approved radioiodine for thyroid cancer treatment. And traditionally, we administer post-surgical radioiodine to eliminate that residual thyroid tissue and decrease the risk of recurrence. But we are studying what patients benefit the most from this, and the guidelines are really starting to encourage personalizing this decision. So why do we give radioiodine? There are different indications for it. So first there's remnant ablation, and that's to destroy thyroid remnants. So that is whatever little is left behind after surgery, which it's common to leave a little bit of tissue to reduce morbidity with the surgery. So that's considered remnant ablation. And then there's adjuvant treatment where the goal is to destroy microscopic disease, which may not be obvious on imaging or biopsy. And then there's treatment of known metastatic disease that is not amenable to surgery. And we do have different doses we give based off the indication. And although in general, radioiodine is thought to be safe, we do need to weigh particular risk of radioiodine in children, including those short-term effects like salidinitis, which is the inflammation of the salivary glands, and ocular or eye dryness. Then there can also be nasolacrimal duct obstruction, which is the obstruction of the tear ducts, or bone marrow suppression. And there are concerns for long-term effects, which are more likely with repeated doses that need to be better studied. So this is also being reflected in national data. Experts are becoming increasingly aware that not all patients may benefit from this radioiodine treatment. So there's multiple limitations to it, and that's why we're seeing here the trend towards surgery without radioiodine, particularly in these pediatric patients that have a less than 4 centimeter tumor. But really, that's more for our low-risk population that we're reducing that automatic prescription for radioiodine for. And I also want to add, since we are at a large referral center, I'm at MD Anderson, we do have access to a meaningful amount of cases, particularly advanced cases. And Dr. Wagesback and our team have really been trying to study what the effects of these different interventions are. So particularly, we wanted to look at our patients who had not received radioiodine. So we had 93 patients who were pediatric age with stage 1 papillary thyroid cancer diagnosed between 1990 and 2021 who had over a year of follow-up. The majority did undergo total thyroidectomy followed by 20% lobectomy. And although the majority were low risk, we had about a third be intermediate and high risk that did not get radioiodine in the situation. And when we look at the after follow-up of a median of 6 years, 95% remain disease-free, which really is amazing and shows that we can have these excellent short-term outcomes without radioiodine in select patients. Certainly, when it comes to intermediate and high risk, we oftentimes go through the process to see if they could benefit from it, but these particular patients that did not get it had no evidence of disease on their tumor markers or on their imaging, and that's why they qualified for this. But it is, something that we need to continue to study. However, we are seeing really excellent results in certain populations. And I know this is a lot of information, but the takeaway on this slide is that for those intermediate and high risk patients, we do that whole body scan after they've undergone the iodine withdrawal and the thyroid hormone withdrawal for at least 2 weeks. And then we have them undergo this diagnostic whole body scan. We get tumor markers at the same time, and that really helps guide us on whether they can benefit. So let's say we do the scan, we don't see any uptake. We also have a negative thyroglobulin. That's a patient I would likely not give radioiodine to because I'm not sure that they're going to benefit from it. And on the other end of the spectrum, there can be a situation where we do see uptake and we have a high thyroglobulin level, and that's a patient I would want to treat with radioiodine. And there's a gray zone where, the thyroglobulin is detectable, they have some thyroid bed uptake, which could be just residual normal tissue, but we can't be sure. And that's where we have a discussion with the family and really try to weigh those risks and benefits for that particular patient and come up with a strategy. And then lastly, there could be a situation where, let's say the patient underwent total thyroidectomy, but ended up having a lymph node that wasn't removed, and it's a large lymph node. That's a situation with radioiodine would likely not help get rid of that lymph node if it's large. It's really more helpful in smaller microscopic disease. So that's a situation where we would consider sending back to surgery to remove that. And after we treat the patient, we then transition to disease surveillance. So it is really important that the patient know this is a lifelong surveillance because of the possibility of recurrence. We do follow the thyroglobulin, which is a highly sensitive tumor marker, and we measure this once that diagnosis is established, so baseline, and then we try to use the same lab. We also always try to get those anti-thyroglobulin antibodies, since if they're present, then you know that the thyroglobulin value is unreliable. And we do often see this present. It's about 40% of our patients, but it's still helpful to trend those antibodies and follow the thyroglobulin with the antibodies, as that should continue to decline years after radioiodine, so it can take quite some time. And regarding TSH suppression, this is a form of cancer treatment. I'm going to talk about that a little bit more on the next slide. But I do also want to emphasize the importance of psychosocial monitoring. This is something that, although really at our visits, we're focused more on the physical and on the disease and how to manage that, really the mental side is also so important. And I'm really happy that there is a keynote focus on this today. And that I think there's another session maybe at the same time right now that's also focused on managing the anxiety distress associated with this. So we always try to connect our patients with our excellent social work team, and then go from there in terms of what further resources are needed. But I think it's really important to acknowledge that and to make sure that it's getting addressed. And in addition to the thyroglobulin I mentioned, we also trend that thyroid stimulating hormone. That's the hormone that comes from the pituitary gland. And we also monitor the free thyroxine, the T4, which is the hormone that we're replacing with the levothyroxine or the Synthroid. And this actually comes from data back in the 1930s, where there's a surgeon who reported 2 children who had pulmonary metastases that actually shrunk when he gave them the thyroid extract. So we do consider, again, this TSH suppression is a form of cancer treatment, and higher doses are needed for suppression compared to simple replacement. So that's why I always try to remind my patients that I want to be the one managing those levels rather than maybe a local pediatrician who's not aware that we're trying to intentionally suppress those levels, and they may be flagged as abnormal on on their local labs. So I try to be the one that checks it and manages it, unless they have another local endocrinologist that's comfortable with this. And then we do have levels of TSH suppression recommendations based off the risk of recurrence. So we try to suppress it more in our patients that are high risk. And then despite those regular surveillance intervals, there is the possibility of progression, although it's quite rare. And for metastatic disease, we have some additional considerations. I'm only going to briefly chat about this because Dr. Wagesbeck is going to give an excellent lecture. I do encourage you to go to his as well. He's an expert in this field. But it is important to just at least briefly mention that metastases are very common in pediatrics, more so than adults. So we see over half our patients with lymph node metastases, and we see about 5 to 16% develop lung metastases, although it's really rare to see metastases elsewhere in the brain or bone. And really, in order to understand how systemic therapy works, which is now being an option for progression, it's really important to understand the BRAF and MAPK pathways, which are controlling essential cellular processes. And it's really hyperactivation of this pathway that is implicated in multiple cancer types. And that's why we're using certain therapies to target parts of this pathway, the parts that are being hyperactivated. And to see what part of that pathway is being turned on, we perform molecular testing. And that's particular in progressive disease. That's when we're doing it more so. And that's because over 75% of our pediatric patients do have targetable mutations, which is good news. And as you can see in this picture, when we compare the molecular profiles of pediatrics and adults with distant disease, the majority of these are fusion genes in pediatrics, and that's in comparison to adults, which are majority BRAF, V600E. So gene fusions are normally genes that are not neighbors, but then through these cellular processes and mitosis, meiosis, they get placed next to each other. And then one gene drives that second gene into that hyperactivation, leading to the thyroid cancer. And then this is a list of FDA-approved systemic therapy for pediatric thyroid cancer, which you can see includes targeted therapy mainly for age 12 and up, but there are some younger groups approved for. And there are a lot of caveats to the systemic therapy. So we always need to assess what the significance of the progression is, because it is very common for this to be very slow growing. So, how much is this going to benefit the patient? And we have to ask if the progression is resectable. And we remind our patients that it's not a cure. It's more so for potentially shrinking the tumor and keeping it at bay. And we don't know how it affects yet the long-term survival or resistance, how long to continue the therapy for, because in adults, they're really using this for the rest of their lives, but we don't want to commit children to this. Especially with concerns of quality of life and long-term effects that we still need to understand and study. So this is an ongoing field of research that we need to explore more. And I know we went through a lot of information, so I just want to give a few takeaway points that overall we see excellent survival outcomes, and our goal is to do no harm. We have been rethinking that traditional prescription of total thyroidectomy and radioactive iodine for everyone, and really trying to personalize the decision instead. And the majority of our patients do have those mutations that can be targeted if there is progression, but we still need to understand this better. And there are many open questions and opportunities to further study this, which I hope to do. And I do want to thank my colleagues at MD Anderson. I'm happy to take any questions, and I'm going to try to open up the chat so I can see. Okay, so the first question I see is, do you have any studies regarding children diagnosed with follicular thyroid cancer? I know it's very rare, however, I believe we're seeing more of it. I love this question because this is an area I really want to explore, and you're totally right that we do not have good studies on this. So this is something that now that we are consolidating our data with other institutions, and this is through what's called the CAT-C, so the Consortium of Adolescent and Pediatric Thyroid Cancer, that multiple hospitals are joining so that we can group our data and look at follicular thyroid cancer in bigger numbers, because you're right that papillary thyroid cancer really has dominated the research area, because that's just the bulk of the patient population we see. So it makes it more challenging to study follicular thyroid cancer. So I'm hopeful that once we group our data, we'll be able to look into this and answer more questions regarding follicular thyroid cancer, because it is different from papillary thyroid cancer. And we know in these situations that vascular invasion is very important to look at and understand so that we can better personalize the therapies and understand prognosis. So I'm hopeful that in our future talks, we'll be able to focus a little bit more on this. The next question, is it helpful to test CEA, thyroglobulin, and thyroglobulin antibody investigating and monitoring thyroid nodules for thyroid cancer? That's an excellent question as well. CEA, I mainly get in neuroendocrine tumors, not for thyroid nodules, thyroid cancer. So I mainly look for that in patients that we suspect may have medullary or other types of neuroendocrine. But certainly with thyroglobulin antibody, we don't have good studies that show patients being followed just for thyroid nodules, because there is a different algorithm we follow, and it really depends on how suspicious we are of these thyroid nodules. Oftentimes I do get a baseline thyroglobulin and thyroglobulin antibodies when I first meet the patient, especially because I'm at a referral center where a lot of these nodules that come to me are already suspicious. So I do have a biased population in that way. So I tend to get that at baseline and then after removal. But certainly it's different when maybe it's a nodule that's deemed to be benign. Then I'm not as tempted to follow that in terms of the thyroglobulin, but I would be getting ultrasounds likely yearly at least, and then that's something that's spread out over time if it's something that's been determined to be benign. And then the next question I see is, my 13-year-old has been recommended to take Retevmo. Should I be concerned if it's in his infancy? So this is a tricky question, because it really depends on the situation. With any intervention, we have to weigh the risk and the benefits. So it really depends on what the extent of disease is seen, and whether it was resectable or not. I assume this has been a situation where they've already undergone surgery, and maybe that there's some remnant disease or progression of disease. So, this is something that, again, we are studying and understanding how it affects children. But as long as the benefits outweigh the risks, then it is something that we also offer at our institution for our patients that qualify, that do have significant progression. Or maybe there's a situation, we've been exploring this in situations where kids that have poor radioiodine uptake but may have lung metastases or other metastases, and we really want to optimize that. We're learning that targeted therapy prior to that initial radioiodine may benefit them. So there's different situations where the benefit may outweigh the risk. So it really depends on the situation, but I do encourage you to speak with your provider and make sure you fully understand those risks and benefits, and what the goal is with it. So great question. Oh, and I think you followed up. He has a RET fusion. He has not had RAI. Oh, got it. Okay. So then maybe it's that situation I mentioned where we're trying to optimize RAI. So this is a really interesting topic that we are also studying, and we are a study site for it. But we are trying to see, because lung metastases are really challenging to cure. and majority don't get cured from that, although they can stay stable for many, many years and not cause symptoms in a lot of our patients. But we're trying to see if we can cure it by optimizing that first dose of radioiodine. So I think it sounds like maybe that's the approach they're taking, is giving short-term sulfatinib, which is great because it's I think the shorter amount, the better, right, if possible. So if this is a short-term offering of the medication prior to radioiodine, just to get the most bang for your buck for that dose, it is something that we're really thinking might benefit our patients, but we still need more information. We have just small case studies that are supporting this, but again, we need to have bigger numbers and understand this better. We are studying this currently, so we hope to have more data on that in the future. And my daughter is 9 years old. She has PTC RET. The clinical trial for sulfatinib is closed. What else is there? Our team believes she may be RAI refractory. So there's always the potential for off-label use. If it's not through a trial, then there is off-label use that you can discuss with your provider. Of course, that depends on the comfort of the provider too. At MD Anderson, we are comfortable using these therapies because we got trained to do them. So, we're always happy to take new consults if you want to come down to Houston. But yes, there is the possibility of off-label use if you don't have a trial available to you and if you're interested. And again, I encourage you to discuss the risks and benefits of that with your provider too. Really great questions. Let me scroll down. Okay, yes, they plan for 3 to 6 months and then radioiodine for started lung metastases. Yeah, so we are determining what the best length of therapy is, and that's pretty standard. On the adult side, they've done as little as 1 month, and but on the pediatric side, we're thinking we are trying longer, about 3 to 6 months. So 6 months is very reasonable, or 3 to 6 months is reasonable prior to that first dose of radioiodine. So yeah, that's something that we are exploring.